Thank you so much for that wonderful introduction. I appreciate the invitation and very much appreciate the purpose and mission of CSTAR. So very glad to be here today. I am going to talk about the psychological and social aspects of living with aphasia, and I emphasize the word living to sort of encompass strength-based interventions and supports that can help promote quality of life. And so we'll talk a little bit about those today and things that can be applied in different healthcare settings. So we'll talk about the psychosocial aspects. We'll talk about the family system and its interaction with aphasia. We'll talk a little bit about family and care partner adjustment and the need for psychosocial and family interventions. And then we'll go through some actual disability affirming strategies that can be applied in different clinical settings to promote psychosocial health outside of language or in addition to language. So I usually start off a presentation like this with stating that psychosocial factors often, if not almost always, impact quality of life after disability to a greater extent than do biomedical factors such as the type and severity of injury. And I know for many that might seem surprising given the impact that aphasia and language disorders and communication disorders have. But what we do see is that their overarching things that lead to enhanced quality of life a lot of times do have nothing to do with biomedical or aphasia recovery. So when we look at biopsychosocial factors that commonly impact quality of life in persons with disability or aphasia in specific, we have a number of different variables. And today I've highlighted the ones that we're really going to talk about, and that's more the psychosocial aspect. So we're going to talk a little bit about the interpersonal psychological variables. We're going to talk about interpersonal experiences. We're going to talk about the family system and their response. And then we'll talk also about sort of the larger community and social environmental aspects of recovery as well. But know that these other things, such as the biomedical aspects, the quality and type of and access to rehabilitation services, as well as larger legislative and funding priorities and initiatives, all have an impact on people with disabilities and their quality of life. So this is a heavy screen. It has a lot of words on it, and it's definitely not what I would consider aphasia accessible. And so I would, of course, change how I show this if we were in a community of stakeholders with aphasia. But I wanted to be able to show on a slide the various ways that psychosocial, or various ways in which aphasia impacts individuals psychologically and socially. At the individual level, we see difficulties with psychological adjustment that create mental health issues, reduced self-confidence and self-esteem, social isolation, and a reduction in social activities, emotion dysregulation, irritability, anger outbursts, frustration, and then some of the cognitive and executive functioning challenges that often accompany aphasia as well. Then when we look at the family level, we see that there's also family system issues that really impact quality of life. And that would be the family adjustment or the caregiver adjustment and how they're responding to the onset of aphasia. Role changes are often required. Changes in relationships, parent-child relationships, or intimate relationships often happen. Of course, communication difficulties and misinterpretation. We know that there's increased psychological and physical health issues in care partners and caregivers of people with aphasia. And of course, the general stress that comes with navigating the insurance system and the rehab system, and some of the financial difficulties that accompany that as well, especially those from marginalized or low socioeconomic populations. And then lastly, I'd like to talk about the larger community level variables that impact quality of life. So these are things like difficulty reintegrating back into the community, work, school, leisure. Depending on where you live, having a lack of local accessible community resources, having a limited support network, especially if you're in rural or certain urban places, the general structural and systemic barriers that exist for people with disabilities in healthcare, in different organizations. There's still a lot of stigma that affects how people interact with those that have disabilities and those specifically that have aphasia. And so these are some of the things that we see from literature as well as from clinical experiences that really do impact quality of life and rehabilitation outcomes in individuals with aphasia and their families. When we talk about the individualized response, of course, varies based on a lot of different factors, right? But in clinical experiences, we do tend to see some themes in terms of how individuals as well as their family members respond. Anxiety and fear is an overarching one. I put that at the top there because that's something that is just, it's a normal consequence of aphasia, and it's also something that really impacts quality of life. Anger and irritability, of course, comes with having communication difficulties and not being able to express the things that you want to express through verbal communication. PTSD, trauma responses can happen, especially if the onset of aphasia comes from a traumatic incident. But the onset of aphasia itself is a trauma. Confusion, shock, sadness, loneliness, depression, which we'll talk about it shortly, and then obsessive compulsive ruminative type symptoms, which is focusing over and over and over on something and not being able to move on until you get through it. And that might be trying to say a word or trying to express something and ruminating and focusing on it for so long until you can actually get it out. But it can interrupt your relationships and your quality of life too. And the important thing that I think probably most people here know, but that I always like to share with most clinicians is that language fluency, expression, and comprehension are all very much impacted by mental health. And if you're experiencing higher levels of anxiety or related negative emotions, your language is affected. And so, especially early on, if someone has anxiety, experiencing depression, experiencing some other mental health response, this can actually impact and in some ways invalidate communication assessments because the communication is so impacted by these kind of emotions that if they're not attended to or if they're not considered, there can be erroneous conclusions made. Another thing we often see in individuals with aphasia is losses. And so grieving becomes a big part of the process, right? A loss of identity, a loss of a sense of self. It's not uncommon for individuals to come into the clinic and say that they have to relearn who they are, what they like, what they enjoy. And when you're trying to reorganize your identity, midlife or later life, it becomes a very arduous and difficult journey. Other things, of course, that come are loss of abilities and skills, loss of relationships, loss of power, loss of social or family status, loss of employment and leisure, loss of control, right? Feeling like I have no control over what's going on with my aphasia or my disability. And that's, of course, associated with depression. And then also loss of finances, health, self-confidence. And so rebuilding a sense of self, helping a person develop identity and provide and engage in activities that are meaningful and that meet their values is a really important part of promoting psychosocial health in any setting. A lot of times when we talk about disability, we talk about adjustment to disability or adaptation to disability as if it's an endpoint. And that's just not the case, right? Disability, and in specific aphasia, reoccurs through and is problematic at different points in life. And that often is during transitions, right? Transitions, whether it be to school, to work, changes in relationships, changes in where you're living, changes in activities that you're doing, changes in family. All of these can create new complications or new stressors. And so I have this little uh, uh, cyclical thing here that basically shows, you have aphasia adjustment, you have that initial stress and response, you experience psychosocial difficulties, then ideally you're utilizing coping skills, problem solving skills, your social network to help bring back to homeostasis or stability, right? And then usually there's another transition that happens in life, right, that creates a similar type of cycle. And so this isn't an endpoint, but oftentimes we call it a cyclical journey. Another really important component and that we focus on, and that I especially focus on, is the family system. And what we do see is, while there's an individual adjustment that occurs, right, the social community and family also must engage in an adjustment process, and they must accommodate and adjust to this new normal. And if families are not adjusting well or not able to adapt roles, this creates systemic problems in the family that ultimately impact quality of life and rehabilitation. And so the development of new roles and negotiating new roles in the family, in the microsystem, and as you can see here, I have a diagram that mimics Bronfenbrenner's ecological framework, showing the different systems around an individual that impact an individual's well-being and quality of life. And at each of these levels, there is a certain adjustment that must occur. And so while we can work with individuals and families, there's also an encouragement to work with community systems to help adjust, adapt, and accommodate people with aphasia. When we think about caregivers or care partners, it is in many ways central to working with clients or patients with aphasia. And I really like this quote here. And it says, when one becomes a caregiver or care partner, one frequently finds that the entirety of one's life has been restructured, both its social exterior and its psychological consequences. And I think that explains a lot. And so when we think about caregiver burden, that becomes a very important thing to assess and look for. Because if caregiver burden is present, or caregiver stress or burnout, it likely means that the individual experiencing aphasia is not getting the support and care that they need as well. And of course, when one family member no longer communicates in the same way, this affects the social bonding in families, family dynamics, and then you add in the other sort of neurological, neurocognitive aspects, and inevitably, family system and caregiver issues and relational issues in the family become very common. And as a clinician, it's something that I often work with, and I often am addressing. So why are there, what's the research out there in terms of why psychosocial supports are needed? And there is mixed data in terms of the prevalence of depression. there's studies that show 20-ish%, upwards of 60%. And a lot of that has to do with difficulties in assessing for depression and in utilizing valid assessments for depression. We also see that in a fairly recent study, almost half of individuals, about 44 to 46%, with aphasia experience anxiety. We also see in a very recent study that adults with aphasia are 7.4 times more likely to exhibit post-stroke depressive symptoms than adults without aphasia. I think that is a tremendous, I mean, when you look across disability categories, that is a tremendous difference. And this last data point is even more shocking. That less than 1% of those in the aphasia population actually receive direct treatment for psychological distress. That is, I work with a lot of different disability communities, and that is probably the lowest statistic in terms of utilizing mental health services that I've seen across any disability category. On the right here are just some other reasons why why I am seeing individuals or family members that have been affected by aphasia, but also that are very common in the literature. Right? Stress and fear associated with the new functional limitations, relationship and marital problems are huge, and that's a lot of what I work with as a mental health clinician. But depression, caregiver burden, the social communication difficulties and social isolation that results from it, and as well as what we would call more diagnosable mental health conditions such as depression, major depressive disorder, post-traumatic stress disorder. These are a lot of the things that we do see present in significant rates in this population. The psychosocial supports are really important and needed. And what I love about life participation interventions is that they overlap substantially with a lot of mental health and psychological goals and outcomes. And so I encourage collaboration because I believe life participation interventions and supported communication is necessary for mental health counselors and professionals to address this population, but also training and counseling skills and brief psychological approaches for mental health professionals can help speech language pathologists feel more comfortable addressing psychosocial health or mental health needs in their clinical setting. So for sake of time, I went through that a little bit quick. I imagine some of these topics are not totally new, but I wanted to make sure that we had enough time to go through some of the more applicative components of the presentation. And these are more strategies that, based on what we know about psychosocial health of people with aphasia, these are strategies that can be implemented and integrated across the whole continuum of care. And so no matter where you work, there's different ways in which you can support psychosocial health outside of what you also do, which is, of course, addressing language recovery and neurocognitive recovery, which is very contributive to quality of life. But there's also things that are low-hanging fruit that can be done in clinics to help support other aspects of psychosocial. This is another sort of wordy slide, and I don't know if we'll go through all of it, but I wanted to be able to put up here what we mean when we say disability affirming strategies, right? And what we really mean by this is that disability is not something to be seen as a negative. Disability is just another form of diversity, like age, gender, race, ethnicity. And so being able to provide supports and interventions that help to really promote disability as something that is not to be ashamed of, but to have pride in, to be happy about. And I know that may seem a little bit unusual, but these are some of the things that are encouraged. Of course, providing accessible practices and accommodations uh, for communication needs or physical needs or cognitive needs, helping to talk about disability advocacy, using language preferences that are most appropriate for the individual. And people in the disability community often have different ways in which they want to be addressed. And so sometimes asking how they would like to be referred to can be very empowering and important. But talking about ableism, encouraging self-determination and autonomy, uh, being honest about the different discriminations and populations that experience discrimination, um, and helping to challenge ableist beliefs and attitudes, right? Even empowering and educating others, and ultimately highlighting the client's voice and lived experience as very important in all aspects of treatment. When we think about assessment processes that are disability affirming and person-centric, meaning that they are designed to empower the individual with a disability and their families. And so what's different about this is that these assessments are different than the maybe usual clinical assessments. These assessments are more about figuring out what supports are needed by the person with disability and their family to attain optimal functioning. And it involves the person and their families as active participants throughout the assessment process as much as is possible. And that means helping them decide what assessments to do, helping them helping you understand what's important to them. What outcomes are most important? What are the things that they desire? And as best as possible, developing and designing treatment around that so that it's a collaborative approach as opposed to a more authoritative approach without the client's input. And on this left side here, we see that these are sort of the principles of what we would call person-centered assessment or treatment. And it's really many of the things that I just said, right? Emphasizing the viewpoints, including them throughout all aspects of the assessment and intervention process, being clear, transparent, honest, and incorporating client values at every aspect. So when we think about clinical recommendations or strategies, another thing that can be helpful is incorporating some assessments or screeners for different risk factors, right? And what we mean by this is if we have an understanding of those risk factors or protective factors that can either lead to psychosocial difficulties or protect from them, we have some good information about what parts of treatment we should focus on. Right? And it helps us understand what are the psychosocial supports that are needed. Now, I fully am aware that in a average clinical appointment, being able to assess all of these things is not likely. But I do believe, and research suggests, that if we can identify some of these risk factors early on, we can be able to more appropriately individualize treatment, and we can utilize resources more efficiently and effectively. And while I won't go through all of these different risk and protective factors, know that there is different levels in which we can assess, right? The family system, the community, the individual, both psychological and demographic factors, and provider factors. And so being able to integrate an assessment process that highlights things that might lead to psychosocial difficulties is important early on because it helps us know what supports are most needed in the treatment we provide. Now, there are going to be times, and there are many times, that individuals with aphasia or their family members may be experiencing mental health issues or symptoms that are pretty significant and even outside the scope of the speech language pathologist's counseling role. And in these situations, we just would recommend that you have some process at your organization, right, for understanding when there might be a red flag or when there might need to be a referral to a mental health professional or an outside professional outside of speech language pathology. And tapping into those aphasia specific resources and helping the client know that, there's not a lot out there. There's more in the SLP world. There's a good amount, but outside of your profession, there is not much going on. And so being able to just validate some of the challenges of that and helping the client know, the patient know that, you're on this journey with them to help them find the resources they need. And then I just leave with some questions as you think about your organization. Does your work setting have a mental health, or medical, or community supports referral process in place? If so, what does it look like? Is it clear to all the therapists and providers there? And are providers trained to identify some of those risk factors, some of those red flags that may be in need of referral? And so just having some kind of systematic process for addressing this, given what we know about the prevalence of mental health concerns and difficulties in people with aphasia and their families. What we also see that can be helpful is something that we call multiple family group treatment. And there are actually already a number of speech language and aphasia programs that in various ways do this. And sometimes it's almost like a support group, except what it is it's multiple families, right, that are experiencing aphasia that serve as care partners, and that also maybe other members of the family, and they meet together to help normalize the caregiving stressors and experience, to help improve each other's social supports and social networks, because having relationships with people that know what you're going through is really valuable and important. Helps provide education about disability, and ultimately research suggests that improves individuals and caregivers' ability to cope and utilize stress management strategies. Other sort of family supports that are recommended in the literature and that I also clinically have seen be very beneficial are mental health counseling and family therapy, different family support, brain injury, or developmental disability programs in the community. Of course, aphasia, stroke and brain injury associations, caregiver resources and caregiver-specific support groups, and then, of course, support groups in general for aphasia and related disabilities. And I do facilitate a few of those support groups, and it is amazing the type of empowerment and support that you see occur in these groups. Now, I'd like to, we're at 12:31, so we're doing good. And I want to make sure that we have a little time left over so that we can have any questions to address or any comments. And so this last section is going to talk more about other clinical strategies that you can do, that research literature suggests are important for improving psychosocial health. So ultimately, when we think about psychosocial interventions, we think of psychological interventions as those that sort of target how the clients perceive and cope with disability or the family, while social interventions target more the environment and the support system and the community around that individual. And so integrating evidence-based psychosocial treatments into any part of the care continuum is really important, valuable, and totally doable. Many of you have probably heard of cognitive behavioral therapy. It's probably one of the most well-known, well talked about forms of counseling and psychotherapy. But this has been shown to support and improve psychosocial health in individuals with aphasia, stroke, and brain injury. And it is an evidence-based treatment that reduces stress and promotes well-being and empowerment for persons with disabilities. And the basic premise of cognitive behavioral therapy is that emotions are really difficult to change directly, right? And so CBT says we target emotions by helping to change thoughts and behaviors that contribute to the distressing emotions. And so it's doing activities that help promote healthier adaptive thinking and that help promote healthier behaviors. And most any healthcare provider can incorporate CBT strategies. So the main goals of CBT are to build skills that enable an individual to be aware of thoughts and emotions, to better understand how situations, thoughts, and their behaviors influence their emotions, and to improve their feelings by changing dysfunctional, maladaptive thoughts and behaviors. Now, the important thing here is that the goals should be, of course, client informed. And the clinician themselves has to be aware of acting on their biases for what they think are dysfunctional or not functional thoughts, because it changes based on culture. But ultimately, it's the client who's going to help identify what are the thoughts or behaviors that are leading to these emotions. And so some of the strategies that are common in CBT would include functional assessment. And this is just basically looking at, what are the things that lead up to that emotion or that emotional experience, and what are the consequences of that? And can we modify that or work on modifying those things? Helping to develop client-oriented goals, brief ongoing evaluation of mood, behaviors, and social supports, doing activities to address maladaptive beliefs, and then teaching coping, problem solving, decision making, and self-management skills. So a lot of education. And in particular, some of the things that can be incorporated into aphasia care, like I said, are education. Homework is something that I know doesn't sound great, but it's things that can be done at home. Bibliotherapy is simply giving reading resources and things the individual can read, but also incorporating mindfulness training and skills, incorporating problem solving strategies, helping to develop thoughtful planning approaches, helping to develop activity schedule for pleasant, positive activities, helping them to reevaluate or reappraise situations to be more helpful to them. And active acceptance is a big part of it as well. Instead of avoiding, it's about helping to accept. And many of these things can be done. And here's just a quick overview of some screeners or some measures that you might utilize with CBT to measure mood. I think many are probably familiar with the Aphasic Depression Rating Scale. There's the Visual Analog Mood Scale. There's the new DVAMS, which I think, I have not used it, but you are able to go online and utilize it for free, or at least try it out for free. And it has the client basically change how a face looks to match how they feel. And so this is showing to have some really good efficacy. And it's something that while still early on, is something that is being utilized to measure mood. And the zones feelings are things that can be utilized with any population, but oftentimes are utilized with younger individuals with developmental disabilities. Another common, well, maybe not common, but another thing that can be incorporated is something called acceptance and commitment therapy. And acceptance and commitment therapy grew out of cognitive behavioral therapy. And basically, the goal with ACT is to improve quality of life by decreasing experiential avoidance. Right? That would be social isolation, lack of engaging in relationships, lack of communication, avoiding things that cause distress or anxiety. So decreasing that avoidance and increasing psychological flexibility, right? And this is, in other words, this is our ability to adapt to new situations. And this is supported by a number of activities as well that can be integrated. But we define psychological flexibility as contacting the present moment fully as a conscious human being, and based on what the situation affords, changing or persisting in behavior in the service of chosen values. So in essence, it's helping to develop ways of navigating that you can adapt and stay in line with your chosen values, right? So ultimately, it's all about maintaining the client's values and goals. And mindfulness is a central part of this. And while we could spend a whole time talking about mindfulness, I encourage you to look into it a little bit more. It helps with acceptance. It helps with being not judgmental, right? Not judging ourselves because of what we're thinking or what we're doing, which can be a big part of distress for people. And being in the present moment. Because oftentimes when we think about anxiety and depression, anxiety is a focus and rumination on the future of what's coming. Depression tends to be ruminating about the past, right? And in both these situations, you're not in the present. And in the present is where you can experience joy and you can experience, active living and engagement. And so some of the principles that we see down here, which I'll show on the next page, and each principle has associated homework and activities. So I encourage people to look at ACT and see if they can incorporate anything. But there are 6 components to this, and I won't really spend too much time on this, but just know that activities help with the individual being present, help with the individual identifying what values they have and what they want, which can be really important for people that are trying to develop and create a new identity or find their identity. Commitment is taking action to pursue the things in life, right? So despite how you feel, moving towards behaviorally the things that you enjoy. Seeing yourself as unchanged over time, because sometimes when people experience crises or disability, they start to see themselves as damaged, and that can have a real impact. And so being able to see yourself as, in essence, the same person, not damaged, is something that is also can be very valuable. Diffusion is this notion of being able to notice your thoughts without over-identifying with them, right? I'm upset, or I'm feeling upset, not I am upset. I'm feeling upset. I have a thought that comes in my mind that's negative. Instead of holding on to it, I put it on a leaf and I let it go down the river. These are different activities to help undiffuse yourself from your negative thoughts. And then ultimately, reality acceptance. And these are just a few things. Again, I encourage you to look at your resources and look up ACT, but here's just a few things that can be utilized to help with teaching some of these skills or identifying values. And then finally, I wanted to talk briefly about behavioral activation, and we'll come to end here in just a few minutes, or about 5 minutes. But behavioral activation is a part of acceptance and commitment therapy. And what behavioral activation says is it assumes the key to changing how people feel is helping them change what they do. And so this is very adaptable for people with aphasia, where verbal communication can be very challenging. This approach focuses purely on behaviors. And so it's about helping to develop activity schedules of valued activities that individuals do regularly throughout the week, whether or not, without being affected by how they feel. Because the idea is that if you do the activity, the valued activity, even if you're not feeling well, there will be a positive consequence that comes from that. And so this approach was based on a framework of depression that says the more we disengage from pleasurable activities, which comes with depression, the more social isolation we have, and then the more depression we have. And to break that cycle, instead of avoiding pleasurable activities, it's about developing activity schedules to ensure that you're engaging in them despite how you feel. And this is just a sort of a linear process of how behavioral activation is done, and of course, communication supports, visual supports are encouraged to be added throughout. But it's basically activity scheduling, monitoring mood, making sure, this is important, that the goals or the activities that you schedule are about enjoyment and are relatively easy, because you don't want to create activities that someone does and then fails at or can't do, because that can decrease their self-efficacy and contribute further to social isolation. So you want to do activities that they value, but that are also fairly easy and enjoyable to complete. And these are just some visual supports that can be utilized in behavioral activation. And I'm assuming everyone's going to have access to this PowerPoint so you can look at these things. But these are some visual cards that show values that can be utilized. And these cards down here were created by Fiona O'Neill, who is an accessibility advisor in the UK and in Ireland. And they are wonderful. And then up here, developed by Haley and colleagues at my university here, are some what we call life interest and values cards, which are also other nonverbal ways of identifying activities and values that clients can utilize or do. And lastly, just a couple more: self-efficacy and problem solving. These are really valuable skills to be able to learn and can be integrated, because we know problem solving improves competence and self-efficacy and ultimately leads to enhanced quality of life. And here's just a neat little technique called solved that can be utilized, that can be changed to be visual, more visual and less wordy, and that can help with problem solving strategies and those with aphasia and related. And then lastly, social supports. As we know, these are just so important, and we know social support groups contribute positively to quality of life in families, individuals, patients, and caregivers. Social support decreases the risk of mental health concerns and mortality. It facilitates coping and rehabilitation progress. It enhances life satisfaction and well-being. And so developing social supports and social networks should be an important component of treatment in any clinical setting. And I would just ask, how do you promote this in your setting? Do you have support groups? Are there community organizations that you work with? Are there peer or parent mentors? And peer support and mentoring, which is this is the last slide, is also something that we are seeing being able to be really helpful. And so promoting and helping to create peer supports or peer mentors for people with aphasia is really important. We know that peer mentoring improves knowledge and self-efficacy. It improves their own perceptions of their social system and well-being. It enhances community participation, and it even reduces co-occurring medical complications. And then, of course, we see that peer mentees help with encouraging like self-monitoring, help with encouraging even monitoring of psychosocial health and navigating resources. And all of these things mean that you're getting extra social support, you're getting extra education, you're helping with navigating through a very difficult system. And these all have a really important impact in quality of life and rehabilitation progress and outcomes. These are the references here. I thank you so much. I think we did pretty good. And so now I would just ask, thank you again for having me. If there's any questions that or topics that I can address.
Great.
Yep, I can hear you.
Thanks so much. That was an awesome presentation. And I'm sure we have some questions from our room, which includes a number of speech pathologists. Oh, I don't see any. Okay. Oh, well, Sissy, yes.
Yeah, the mindfulness approach, you know, as a speech therapist over a number of years, I've came to realize how important this aspect of speech therapy is. So just thank you for sharing that.
Thank you.
So Caitlin Brooks asks, I love the idea of a peer mentor for persons with aphasia. Any suggestions on how a person with aphasia can find such a mentor?
That's really great. Now, I would say we're lucky here at UNC is we have a peer mentor program that was actually started in our hospital. So you know, so what happens is basically there's someone that runs the peer mentor program, and they have individuals that apply to be peer mentors. And then for those that are newly disabled or newly out of acute rehab that are interested in peer mentors, they match them. And so that's how we do them. Now, another way that I found the peer mentoring to be facilitated in more or less formal ways is through support groups. And this has been actually a really big way in which individuals that are sort of further down the road of recovery or lived experience with aphasia are able to interact, meet, and you know, and consult and exchange information with others that are, you know, earlier on in their injury or their disability. And then the other thing I would just say is advocating for peer mentor programs and training, because there's a number of different peer mentor things for like brain injury. And there's peer mentor programs and training for individuals with brain injury, but advocating for some, you know, development of a peer mentor program within your clinic, within the hospital. But I think it can also be informally done by working with outside organizations or support groups. I hope that helps a little bit.
Great, thank you so much. And yeah, Caitlin says thank you. And Carla Cheney Hendricks also says, thank you so much for a wonderful talk, very helpful real-world tools. Then we have a question from Dina Schwem-Blackett. For patients who are especially withdrawn and self-isolated and perhaps lack motivation to make any behavioral changes, do you have any recommendations for helping encourage their participation in beneficial activities like support groups? And thank you for a great talk.
Yes, great. Well, great question. And of course, this is always the very challenging thing. And you know, being withdrawn, isolating, lack of motivation, these are things that are all very much associated with depression and depressive symptoms. And we know that is it can also be a consequence of high anxiety to integrate back into situations where they may not be able to keep track of conversations, or they are concerned that others might think they're weird or stupid, or, you know, and so this is a real common thing. And the best thing I would say, you know, in terms of just in timeliness of the answer, is that I really think for individuals like this, looking into behavioral activation and looking into some of those supports can be helpful, because behavioral activation is less about less about addressing the lack of motivation, as it is about finding what the individual is willing to do and starting there. Just finding what the individual is willing to do. They're not willing to go to support groups. That's not uncommon. That's not uncommon. What are they willing to do? And being able to, you know, start off small and work up towards some of these things. And I know it can take time, but I think as people, you know, ideally are able to go out and do an activity or whatever it is successfully, it does enhance over time their confidence. And ultimately, you would hope that you work towards, engaging in social activities that are a little bit more stressful, right, initially, because they're building up their confidence over time.
Great. Thank you very
Again, I
much.
hope that was helpful.
Yes, Dina says, great, very helpful. Thank you. Then we have a question from Ellen Bernstein-Ellis. Wonderful topic and talk. Thank you. Any thoughts on work being done to increase access to mental health providers who are trained for supporting individuals with aphasia? I'll give a shout out to Stroke Onward, a new nonprofit working to improve the emotional support after stroke.
Yes, and I would like to tell everyone that I and Stroke Onward developed a program, an educational program for mental health counselors that we've piloted a couple times now. So we are trying. And I am, of course, working to train mental health counselors in my own region and here. But me, us and Stroke Onward. And also, I want to give a shout out to, my goodness, Aphasia Center out in New Jersey. I'm so sorry. I have COVID, everyone, so this is COVID brain. Yes, so we are working towards that, and Stroke Onward is doing a great job really trying to promote education for mental health counselors. And we have and are in the process of doing another pilot of this mental health counseling for mental health counselors.
Cool. And Ellen is helping you out with the stroke brain. It's the Adler Center that you were thinking of.
Adler Center, yes. Gosh, I hope they don't get mad at me. I love them.
Great. Thank you. I had a question, which I wonder if you can talk a little bit more about any ideas you have, or even recommendations about the timeline of when you start to address specific issues. I can imagine, and please, if you disagree, that's fine. I can imagine that one wouldn't necessarily want to start right away in a subacute phase to talk about acceptance and disability, and that you might want to wait with that a little bit, right? So, what are your thoughts?
Yes, I think what's really important to know, is that the things I've talked about today are often things that I'm addressing or I'm recommending for more after acute stay, because early on there is the shock, there is the what's going on, but there's also when you're still in the acute setting, and it's different for everyone, but there's not a real full understanding of the total impact of aphasia. And it's really when you are returning to the community and back to your family system, community system, where you are now re-engaging back in, the systems that you were in, that people tend to really start to experience the full impact psychologically and socially. And so I agree with you that early on, talking about in the acute phase, talking about acceptance, talking about all that. I do think it's too early on. Early on, I think, is more, to me, is about validating the experience, being there to support them in whatever way they need in the moment. But I think a lot of these psychosocial activities are probably more appropriate, not always, but I would say more appropriate for more the, after acute, back in the community, outpatient. But that doesn't mean that some of these can't be utilized inpatient as well. But you're right, early on, there's so much going on that the psychological and social aspects haven't always really haven't really come into full purview yet. If that
Thank you so much. Thanks. I don't see any other questions online. One last look at our own room. No, so I think that brings us to 1 o'clock. Perfect timing, Blaise. Thank you so much. We really enjoyed it. That was super helpful and interesting to our group as well. And I know to the audience online. So thanks everyone for joining. Thank you for giving the talk, Blaise. And we look forward to seeing everyone in 2 weeks' time.
Wonderful. Thank you all so much for having me. I appreciate it, and I hope you all have a wonderful week.